without SCA preparation. Let's look at obstructive sleep apnea. So significant obstructive sleep apnea causes daytime somnolence. This increases the risk of personal injury. Of course, for instance, the person who is driving, for instance, living the risk of a road traffic accident if they're drowsy. This increases the risk of personal injury, especially when driving. Hypertension, strokes, and myocardial infarction rates are all increased. Other causes of daytime somnolence need exclusion. These include poor sleep habits, of course, shift work, working night shifts, evening coffee, restless leg syndrome, consider referral to neurology. So the patient is having, of course, restless leg syndrome is really affecting them, causing daytime somnolence. You need to be on top of it. They have narcolepsy, consider referral to neurology. So prior to referral for assessment of possible or suspected obstructive sleep apnea, consider the following. The available treatments for obstructive sleep apnea are CPAP, continuous positive airway pressure therapy, or mandibular splints, so mandibular advancement procedure, mandibular splints for mandibular advancement. So surgical treatments have unpredictable results, and it is possible they might make the use of CPAP more difficult. So these treatments are only suitable for moderate and severe cases. Patients usually only tolerate the treatment if they have sufficient somnolence to impact on their quality of life. The degree that warrants treatment is therefore determined by the patient and their lifestyle. The Epworth score is a helpful measure in conjunction with clinical assessments. Score is less than 11 suggests sleep apnea is unlikely. 14 or more suggests moderate to severe obstructive sleep apnea. Recently had a teenager with a score of 17, young chap, of course, he's a teenager, normal BMI, and all of that. So the family history of obstructive sleep apnea. So I referred to the pediatric referral. Just always cutting between deciding to refer directly to the sleep clinic or to refer to pediatrics, and pediatrics can then assess and decide you don't want to refer him to sleep clinic. Probably should always refer to sleep clinic, even though he is teenager. Occasional nocturnal apneas may cause alarm to the sleeping partner, but if the frequency is low, then there will be no ensuing daytime step somnolence and no need to treat. The assurance with a referral is sufficient in that situation. So mild or occasional symptoms of obstructive sleep apnea do not require referral, because it is unlikely that treatment will be accepted. There is no evidence of long-term health risk for this group. It is vital that patients with obstructive sleep apnea and daytime sleepiness sufficient to impair driving or the use of machinery are warned of the risks and told to cease immediately pending treatment. We can imagine the SCA, there might be a patient that comes to tell you they feel very sleepy, and then we ask about the eyes, like what are your thoughts about what might be causing this? What do you think? Anything you suspect could be causing it? I tell you, my wife, my partner has, mentioned that I snore a lot at night, and I've read, and I'm just thinking if I have sleep apnea, and they might give you a clue that will now lead you down that route. Then, ask certain questions. Now, referral criteria. Please note referral criteria below are applicable in this referral. Referral submitted without this information will be returned. Completion of a referral form, including Epworth score and Berlin or South Devon, and for Toby and South, or Epworth score is a prerequisite for referral. Completed forms must be attached, blah, blah, blah. Please only refer patients with an Epworth sleepiness score of 12 or more. Prior to referral, exacerbating factors should be considered. Obesity, alcohol, night sedation. So your patient is probably taking Zopiclone at night time or taking Phenergan or Metazine to sleep. You need to consider that. So smoking should be corrected where possible. Now let's look at this Epworth sleepiness scale for sleep apnea assessment. So the Epworth sleepiness scale. The Epworth sleepiness scale is widely used in the field of sleep medicine. as a subjective measure of a patient's sleepiness. A test is a list of 8 situations in which you rate your tendency to become sleepy on a scale of 0. No chance of dozing to 3. High chance of dozing. So, okay, yeah. So it's obviously chance of dozing, no chance of dozing, 0, slight chance, moderate chance, high chance of dozing. So the patient will score each of these questions. Write down the number corresponding. So what's the likelihood of, or the chance that you fall asleep while you're sat down watching TV, while you're driving, while you're sat down as a passenger in a car, while you're lying down to have a rest, in the afternoon, while you're driving and you've stopped at traffic, maybe while you're sat down, of course, while you're resting in the afternoon, after your lunch without alcohol. So you need to explore all of those things. And so you particularly need to explore the patient's concerns. Is there anything you're particularly worried about? And what are you hoping I will do to help, today? This is the Berlin questionnaire for sleep assessments. Do you snore? Your snoring is slightly louder than breathing. It's louder talking, louder than talking, very loud. As your snoring never bothered other people. So the Berlin questionnaire is about the snoring. Has anyone noticed that you quit breathing during your sleep apnea? How often do you snore? So the Berlin questionnaire has two parts. First of all, assesses snoring, and then goes on to assess the symptoms of the aftermath of having a poor sleep, which is the fatigue and excessive sleepiness. So how often do you feel tired or fatigued after your sleep? Have you ever nodded off or fallen asleep while you're driving a vehicle? During your waking time, do you feel tired, fatigued, or not up to par? Yeah. If yes, how often does this occur? Do you have high blood pressure? Is your BMI greater than 30? So, so this Berlin questionnaire is very good because first of all, you need to assess the patient's snoring, in terms of if they sleep alone, they probably wouldn't know, but if they sleep with someone, if they got a partner or a parent or someone that can tell them, or a friend, someone that lives, or a flatmate that can tell them they snore so loudly, you get. Then aftermath, the fatigue and sleepiness that happens in the daytime. And of course, are they hypertensive or they got COPD towards their body weight and height. So Berlin questionnaire results high risk of sleep apnea syndrome if there are 2 or more categories where the score is 2 or above. Okay, let's look at time. Let's look at eating disorder. So assessment of eating disorder. So diagnosis of an eating disorder is based on suggestive clinical features, supported where possible by corroboration from a relative or carer or friend. Be aware that eating disorders can be difficult to detect in primary care, as those affected may be slow to present, reluctant to disclose symptoms, or be unaware they have an eating disorder. They might be unaware they have an eating disorder. A variety of tools can be used for screening and risk assessments, such as a baseline eating disorder assessment tool available on the National Institute for Health and Care Excellence, NICE. A SCORF questionnaire. 2 or more positive answers to the following questions are suggestive of anorexia nervosa or bulimia nervosa. So the SCORF questionnaire, which is, sickness, control. Do you think you see yourself as fats, and does food control your life? And the O is the obsessed. 1 stone, okay? 1 stone. So do you make yourself feel sick before you feel because you feel uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost more than 1 stone in 3 months? Do you believe yourself to be fat, or others say you're too thin? Or would you say food dominates your life? So that's SCORF questionnaire. You need to be asking those questions. protocols from the Royal College of Psychiatrists, which lists clinical features such as low, moderate, or high risk for anxiety and depression. So typically for this eating disorder, you have to find out what the patient's, why they've come, how can I help you? How can I help today? What are your ideas, concerns, expectations, rollouts, all those things. They need to be as finding out, as checking their mood, psychological impacts, mood. Is there anything you suspect might have brought this on? How have things been? Who else is at home? What do you do? What do you do if you're working, and how is work? How are you finding work? Any stresses at work? If you're in a relationship, how is that going? Any stress in the relationship? Is there anything that possibly could be causing a lot of stress in your life at the moment? Have you had a mental health diagnosis in the past? And things like that. And you ask certain questions like this cough, and what's your relationship with food like? Ask that. How much do you eat in a day? What do people say about your weight? How do you see yourself in terms of your body weight? Yeah. So what's your target? What's your ideal body weight? If I may ask you, it's more about having that conversation with the patient than just being robotic and trying to tick off all these cough questionnaire questions. You know what I mean? Assessment may be normal, even in medically unstable people. Severe malnutrition and purging behaviors can lead to another thing important to check today. Engage in compensatory behaviors when they think they've eaten so much, like inducing vomiting, using laxatives, and also might be taking diuretics to lose weight. Severe malnutrition and purging behaviors can lead to life-threatening complications, such as cardiovascular instability, of course, from hyponatremia and hypokalemia, or severe electrolyte disturbance. Primary care clinicians should have a low threshold for seeking advice. Emergency admission may be required. Into the body weight, the BMI is less than 15, you should probably be thinking about supervised refeeding, in the hospital. Take a history about symptoms of eating disorder like changing weight, increase, decrease, failure to thrive, dietary restriction, or binge eating. Fear of gaining weight and body image disturbance. So you ask about perceived ideal weight. Compensatory behaviors, excessive exercise, purging, vomiting, use of weight loss medications. For instance, if a patient is using semaglutide or Olistat, for instance, you can never be surprised how they're getting it. They could be getting those maybe Olistats, illegally or something. Or misusing their mom's relatives Olistats to achieve weight loss. Consider insulin misuse in diabetic patients. Complications of eating disorder such as fatigue, constipation, reflux, hair loss, amenorrhea. Be alert for symptoms responsible of a serious complication require urgent admission such as syncope, green syncope, severe abdominal pain, comorbidities and symptoms such as alternative diagnosis such as inflammatory bowel disease or celiac, so mental health, need to be checking the mood, anxiety, depression, OCD. Ask about, risk of, are they feeling, how if you've had any thoughts of self-harm or thoughts of harming someone, if you feel suicidal. Approximately 20% of people of death in people who are nervous are due to suicide. You can imagine that's so high. That's so high. 20% of people deaths from aneurysm nervosa from suicide. It's horrible. It's sad. So social history and social supports, including stressors at school, work, home, internet, bullying, social media. Consider possibility of bullying and abuse, online bullying, for instance, or even face-to-face bullying at school or at home. For more information, see this. So check alcohol and drug misuse, family history of eating disorder is very important, depression, substance abuse, medication, including over-the-counter medication. Examine the person, calculate the person's body mass index, and compare with previous recordings to get an objective opinion on whether they've gained weight or lost weight, or whether their weight has remained stable. Use central charts in persons who are younger than 18 years of age. It's important to make an early diagnosis in children because there's risk of irreversible growth impairment. Be aware that some people may refuse to be weighed or falsify their weight by drinking large amounts of water beforehand or hiding heavy objects in their clothing. So you need to be very much aware of that. Check vital signs, temperature, hypothermia is a red flag. Pulse, bradycardia less than 50, or postural tachycardia, red flags. Blood pressure checking for postural differences, hypotension, or orthostatic hypotension, red flags. Hydration states, peripheral circulation. Look for muscle wasting and assess muscle strength. Scores of 2 or less, especially scores are falling on the sit-up, squat, stand, and the source test are red flags, scores of 2. The sit-up test, the person lies flat on a firm surface such as the floor and has to sit up without, if possible, using their hands. The squat test, the person is asked to rise from a squatting position without, if possible, using the hands. So it's tells you about muscle strength. They also want to lie down, you wanted to sit up. So you're testing their core strength, the strength of the tummy and back muscles, and even their thighs, because your thigh muscles also play a role in your iliopsoas, in flexing your trunk. And then squatting, you want to test strength. Carry out a general exam looking for complications of eating disorder or signs suggestive of an alternative cause. Consider the need for investigations. Extensive investigation is not usually required in primary care. Most people with an eating disorder will have normal blood tests results, which are a poor indicator of risk. However, some tests may be useful to rule out complications. You also want to ask the patient when last they had something. You want to be sure they're not starving themselves because if they've not had something for 4 or 5 days, for instance, in the caloric intake, you're in the risk of, refeeding syndrome. And you have to start thinking about supervised refeeding. Depending on clinical situation, consider the following investigations in primary care. Seek specialist advice or admitting to hospital may be more appropriate. So full blood count measure, anemia from malnutrition or gastrointestinal losses, or mild leukopenia or thrombocytopenia from malnutrition. ESR, usually normal in people with anorexia. A raised ESR may indicate an organic cause of weight loss. I agree. UNEs, hypokalemia, suggestion of vomiting or laxative abuse. Hyponatremia may be a result of excess water intake. Electrolytes may be elevated due to dehydration. LFT may be slightly elevated for malnutrition. Blood glucose, creatinine, this is chronic hypokalemia, chronic volume depletion can lead to development of kidney disease. ECG, this should be considered for all people with rapid weight loss. Excessive exercise, severe purging behaviors such as laxative or diuretic use of vomiting. Bradycardia, hypotension, caffeine, excessive caffeine, including energy drinks, prescribed or non-prescribed medication, muscle weakness, electrolyte imbalance, previous abnormal heart rhythm. Other tests may be required in more severe cases, or to assess complications. So you might want to do things like calcium, magnesium, phosphate, because thinking of refeeding, these things can be deficient, obviously, malnutrition, and it can even become more deficient in refeeding syndrome, in rapid refeeding, and get consumed by the enzymatic processes. So B12, folate, ferritin, thyroid, follicle-stimulating hormone. So she's having troubles, she's amenorrheic. Want to make sure she's not gone into premature ovarian insufficiency. Or you want to make sure she's not pregnant as well, so you want to do pregnancy test. Okay, let's look at clinical features. And we'll look at management. So clinical features of several, so when we look at the eating disorder, so looking at anorexia nervosa, bulimia nervosa, and then there's a binge eating disorder. The difference between bulimia and binge eating is that in binge eating, they binge eat, and they don't do the compensatory behaviors like purging and all that, excessive exercise, diarrhea. And when bulimia, there is binge eating plus compensatory behaviors. Suspect an eating disorder in anyone presenting with unusually low or high BMI for your age, including children with faltering growth. Water. Anyone presenting with rapid weight loss, change in eating behavior, including dieting or restrictive eating practices that are causing concern to the person, their family, parents, other professionals. People with mental health problems like stress, anxiety, depression, social withdrawal, disproportionate concern about body weight or shape, or control of chronic diseases affected by diets. menstrual or endocrine disorders, unexplained gastrointestinal symptoms, electrolyte imbalance, hypoglycemia, physical signs of malnutrition, such as poor circulation, dizziness, palpitations, fainting, pallor, or presence of compensatory behaviors like laxative misuse, vomiting, excessive exercise. Be aware that eating disorders can occur in anyone at any age and present in people of normal or above normal weight. Risk in young men and women is highest between 13 and 17 years of age. Behaviors associated with eating disorders are often covert, so they try to hide them. Some people may talk openly about eating disorder, others might be unaware that they have one or find it too difficult to disclose. Some occupational or recreational activities are associated with greater risk of eating disorders, such as, of course, sports, modeling, fashion. When you're into highly competitive sports, there's the likelihood that you'll be over-exercising, you're watching your weight so much. And of course, when you're in modern, maybe into fashion, even dance. Eating disorders may present atypically or with faltering growth or delayed puberty in children and adolescents. Other causes must be excluded, but clinicians should have a high index of suspicion in people presenting weight loss, faltering growth, delayed puberty, menstrual irregularities. So if you look at clinical features of anorexia nervosa, so the clinical features of anorexia nervosa, restriction of energy intake resulting in low body weight. So low body weight is defined as less than minimally normal in adults. Maybe let's jump to, people probably know this, let's jump to the management. How do we manage? Let's look at how to manage management of eating disorders. How do I manage suspected eating disorder in primary care? Consider the need for emergency medical or psychiatric admission for anyone at risk of serious physical complications, suicide or self-harm, serious self-harm. For all other people with a suspected eating disorder, refer immediately to an age-appropriate eating disorder service for specialist assessment and management. Do not use a watchful waiting strategy for managing eating disorders. So as soon as a patient establishes a suspected eating disorder, refer immediately to the eating disorder assessment service. Depending on locally agreed care pathways and service provision referral. Referral may be to community mental health team, maybe to CAMS, child and adolescent mental health team, or a specialist eating disorder unit. Consider simultaneous pediatric referral for children and young people with eating disorders. The urgency of referral depends on specific clinical situation, on the specific institution and the clinical judgment. If unsure, seek advice from the nearest specialist eating disorder service. While awaiting specialist assessment, arrange regular review with frequency depending on the clinical situation. For example, weekly children to monitor level of physical and mental health risk and consider the need for urgent admission, further investigations, and increasing the urgency of referral. Consider the possibility of complications and monitor/manage appropriately, seeking specialist advice. Ensure that people with comorbidities, such as diabetes or pregnant women, have specialist interest. Increased monitoring and alterations to treatment may be planned. When prescribing medication for people with a suspected eating disorder, take into account the impact of malnutrition and compensatory behavior on medication effectiveness. For example, the oral contraceptive pill and the risk of side effects, in particular, cardiac side effects. When should I admit a person with a suspected or confirmed eating disorder? So when should I admit someone with a suspected? What are the indications for acute admission? Be aware that some medically unstable people with eating disorders can appear deceptively well. The low threshold for concern is essential. Seek specialist advice if unsure, which means some could be unwell or they might pretend, because you know that once the doctor detects that they're unwell, you're likely going to be admitted. Consider emergency admission of anyone at risk of serious physical or psychological complications, such as severely compromised physical health, including BMI or body weight below a safe range. The degree of dietary restriction and rate of weight loss is important. For example, more than kilogram per week indicates high risk. Person losing more than 1 kilogram every week. That's so rapid. Cardiovascular instability, for example, bradycardia of 40 or less, tachycardia on standing, prolonged QTC, hypotension, including postural hypotension, hypothemia, reduced muscle power on the SUS test, sit-up, squat, stand test, concurrent infection. If they have concurrent infection, overall ill health, or rapid deterioration, abnormal blood tests such as electrolyte imbalance or hypotension, risk of refeeding syndrome, risk is increased by rapid weight loss, fasting for over 5 days, BMI less than 16, compensatory behavior. The BMI of less than 16 is 15 and below. Compensatory behaviors, use of diet pills or diuretics, water loading, excessive exercise, use of laxatives, vomiting, dehydration. Acute mental health risks such as risk of suicide or serious self-harm, consider psychiatric crisis care or psychiatric inpatient care. Discuss with a specialist for ensuring admission to medical pediatric wards more appropriate. Lack of support at home. Consider admission if the person may not be kept from significant harm at home or where the home environment impedes recovery. Detailed information on risk parameters to be used as a guide to level of concern are available from the Royal College of Psychiatrists. For adults, okay. If unsure where to admit, for example, acute psychiatric ward, specialist eating disorder units, or acute medical or pediatric ward, discuss with a specialist. The appropriate place to admit a person with a life-threatening eating disorder is not always obvious and depends on local services and practice. Children and adolescents should be admitted to age-appropriate facilities. So the question is, this person could need psychiatric. So let's assume the person is suicidal and high risk of suicide, and you need to section this person, for instance, section 2, section 3, to a mental health facility, place of safety. But obviously, let's assume their BMI is 14. Let's assume there's risk of, having these electrolytes in severe hypokalemia, for instance. They're losing weight rapidly. Let's assume they've got a blood pressure of 80/50. They're unstable, and they also need an urgent medical attention. You might not be able to provide that medical attention in a psychiatric ward, and you might not be able to provide a lot of psychiatric assessment on a medical ward. So if you get stuck, you probably need to give the medical reg a call, probably speak with the psychiatric liaison team as well, and get the advice on the best place to admit the patient. If a person's physical health is a serious risk due to their eating disorder, and they can only be treated safely as an inpatient, but they do not consent to admission, and consider the need for compulsory admission and seek specialist advice. So at that point, if they have capacity, it becomes tricky. They say they don't want to be admitted. If they got capacity, then you probably may not really be able to do much in terms of admitting them against their wish. They clearly got mental capacity, especially if they're adults. If it's a child, then you might need to involve a safeguarding lead in that decision making to get the right decision. If it's a child who's, for instance, 16 years, they shouldn't have the capacity to consent to treatment, but a 16-year-old child will not have the capacity to decline treatment that is needed. So as long as their parents are able to give consent, if the child doesn't want, then obviously the child will still be admitted against their wish. Let's look at liver function. Yeah. Let's look at abnormal liver function tests. So what do you do when you get an abnormal liver function test results? So when do you repeat? So if you have an isolated raised bilirubin, you repeat it when convenient. Isolated raised, if it's a liver pathology, you won't have an isolated raised bilirubin. You probably have an raised ALT, AST as well. If it's an isolated raised bilirubin, the patient is not jaundiced. The patient is not jaundiced clearly, then you should be doing a fasting LFT sample with full blood count, they say when convenient. So probably in 4 weeks' time, in a month's time, you could repeat that. If there's an isolated raised AMP, ALP can come from bones, ALP can only come from bones or from the cholangiole in the biliary tract, in either intrahepatic or extrahepatic biliary tracts. If there's any inflammation or blockage, you can have raised ALP. So if you have an isolated raised ALP, which means ALT, bilirubin is normal, ALT is normal, AST. Well, depends. Some labs will not do AST routinely as part of LFT. You repeat the ALP, you have to repeat it in 4 weeks' time. Repeat the LFTs with GGT, gamma glutarate transaminase or transferase. If GGT comes back normal, it tells you that there's no problem with the biliary tract. And at that point, you'll be looking for bone causes. So you check vitamin D, bone profile, phosphate levels for bone causes. You also need to exclude pregnancy. This pregnancy can cause a raised ALP, placenta, from the placenta. So if GGT is greater than upper limit of normal, if the GGT is greater than upper limit of normal, then you have to do non-invasive liver screening where you do the photos of the hepatitis screening, hepatitis B, C, A, hepatitis E, serology, you do your cytomegalovirus serology and all that. You do all those non-invasive liver, but you not do how you get out request an abdominal ultrasound. I think GGT is raised, ALP is raised, GGT, you're thinking of hepatobiliary cause, right? If you have an isolated raised ALT, then it depends. If the ALT is lower than 3 times the upper limit of normal, you can repeat it in 1 to 3 months. You also want to check your AST and repeat your full backup. If your ALT is greater than 3 times the upper limit of normal, so you repeat it immediately. If you still, and also add the AST and backup. If ALT remains abnormal, then you need a non-invasive liver and ultrasound. So to check for those hepatitis viruses. Check for those viruses. Now, if you have an isolated GGT, repeating 1 to 3 months. Isolated GGT, repeating 1 to 3 months. Review for significant alcohol consumption, medication history, mainly anti-epileptics, uncontrolled diabetes mellitus, obesity. If still elevated, check LFT. Isolated GGT, I'm wondering why a person wants an isolated GGT, because typically what will make you want to do GGT? Most times you do GGT when ALP is raised. So I'm wondering why someone have an isolated GGT. What led to the testing of GGT in the first place? You know what I mean? You have raised bilirubin with raised ALT or ALP or general referral, because obviously ALP is raised and ALT is raised. You're like, oh, there's something going on, when bilirubin is raised and ALP is raised, we're thinking of something blocking the biliary tract. You know what I mean? It could be pancreas, head of pancreas, it could be cholangiocarcinoma, it could be cholelithiasis, a gallstone in the common bile duct. It's because I added this onto this website because I recently saw a patient, a few months ago, I saw a patient that I thought had Dubin-Johnson syndrome. So what was Dubin-Johnson syndrome essentially? So Dubin-Johnson syndrome, if you have Dubin-Johnson syndrome, your body cannot remove bilirubin waste from the cells, from the hepatic cells. This causes substance like bilirubin to collect in your body, hyperbilirubinemia, which causes symptoms like jaundice. Nearly all people born with Dubin-Johnson syndrome will experience symptoms of jaundice caused by bilirubin collecting in the liver. Jaundice may worsen during times of stress, such as the other illnesses, pregnancy. So you can have fatigue. So Dubin-Johnson syndrome is a benign condition. Hospital imaging and blood tests show symptoms that could show symptoms like deposits that build up in your liver. Essentially, what happens in Dubin-Johnson syndrome is that the bilirubin that's produced in the liver cannot be excreted efficiently out of the liver. So I think it causes more of conjugated hyperbilirubinemia. Treatment isn't really necessary. So whenever they have episodes of physiological stress or pathological stress, and I think when people have jaundice, like transient jaundice that happens and resolves,